Vyzulta, lantanoprostene Bunad ophthalmic solution, 0.024%, is indicated for the reduction of intraocular pressure in patients with open-angle glaucoma or ocular hypertension. Please see important safety information at the end of this video. Choosing Vyzulta for newly diagnosed and/or treatment-naive open-angle glaucoma patients. Hello, I'm Dr. Constance Okeke. I want to talk to you about an experience I had recently treating an open-angle glaucoma or OAG patient, the results of the treatment regimen, and how they inspired me and my colleagues to conduct a national retrospective chart review study. Several factors prompted our desire to conduct this study, which evaluated the IOP-lowering efficacy of lantanoprostene Bunad ophthalmic solution 0.024% in patients who are newly diagnosed with open-angle glaucoma and known to be treatment naive. First, a notable case study of the following treatment-naive patient who experienced a greater than expected response to treatment. This 44-year-old male patient with a family history of glaucoma presented with uncontrolled open-angle glaucoma in the right eye and ocular hypertension, also referred to as OHT, in the left eye, with an IOP of 34 and 25 respectively. The patient was prescribed Vyzulta and scheduled for a 360-degree selective laser trabeculoplasty or SLT. At pre-surgical workup 6 days later, the patient had experienced a 44% reduction in IOP from 34 millimeters of mercury to 19 millimeters of mercury in the right eye and 25 millimeters of mercury to 14 millimeters of mercury in the left eye with Vyzulta monotherapy. For context, the average IOP reduction with Vyzulta observed during the clinical trials was 32% from baseline. This patient's results exceeded my expectations based on the observed IOP reduction after initiating Vyzulta. Vyzulta works through a dual mechanism of action and is thought to increase aqueous humor outflow through the trabecular meshwork and uveoscleral pathways. Trabecular outflow was further enhanced following SLT, which yielded an additional reduction in IOP. The robust clinical response observed in this treatment-naive open-angle glaucoma and ocular hypertensive patient served as a catalyst to initiate a broader study of treatment-naive patients. The second factor that prompted this chart review was our desire to gain insights on this particular patient population. In large phase 3 clinical trials, it is usually not possible to know if a patient was truly treatment-naive. So understanding how treatment-naive patients respond to initial therapy can be challenging based on these studies. Therefore, in our chart review, we wanted to examine a population of patients we knew to be treatment-naive to evaluate their response to initial therapy with Vyzulta. Real-world use of lantanoprostene Bunad 0.024% in treatment-naive patients with open-angle glaucoma. The study examined a total of 65 patients encompassing 125 eyes treated with lantanoprostene Bunad 0.024%, also referred to as LBN, in a retrospective chart review at 9 U.S. ophthalmology and optometry sites. Changes in IOP and responder rates were measured in the overall population and two subsets: those with a baseline IOP of greater than 21 millimeters of mercury and those with a baseline of less than or equal to 21 millimeters of mercury. Patients were an average of 59.3 years of age, with 30 male and 35 female subjects across ethnicities. Eligibility criteria for patients included in the analysis were aged 18 years or older, a new diagnosis of open-angle glaucoma or ocular hypertension, no history of previous IOP-lowering medications or procedures, a prescription of lantanoprostene Bunad 0.024% as their initial IOP-lowering agent, at least 2 follow-up visits after initiation of treatment with lantanoprostene Bunad 0.024%. The follow-ups spanned at least 2 months. The results of the study were illuminating. Overall, 80% of patients achieved a 20% or greater reduction in IOP at their first or second follow-up visit. Mean days to first and second follow-up visits were 43 and 141, respectively. What's encouraging is that the patients in the greater than 21 millimeters of mercury subset, which had a mean baseline IOP of 26.7 millimeters of mercury, achieved a mean 41% IOP reduction, while patients in the less than or equal to 21 millimeters of mercury cohort, which had a mean baseline of 17.4 millimeters of mercury, had a mean IOP reduction of 22%. While prospective data will be needed to confirm the current retrospective study results, the current observations support the use of Vyzulta in open-angle glaucoma patients who are naive to therapy. Results indicate that LBN provides effective IOP-lowering and tolerability in treatment-naive patients with open-angle glaucoma regardless of baseline IOP. No systemic adverse events were recorded in the studied charts. About half of the charts included notations of at least one ocular adverse event, most commonly blurred vision, 15.4%, dryness, 12.3%, itching, 7.7%, irritation, 7.7%, and light sensitivity, 7.7%. There were no discontinuations recorded due to an adverse event. This study was subject to limitations inherent to its retrospective design and small sample size. Each patient served as his or her own control group. Only one of the 65 patients was diagnosed with ocular hypertension. Patients who did not use Vyzulta for at least 2 follow-up visits were excluded, allowing for a potential selection bias towards patients whose experience with LBN was effective and well tolerated. The safety and efficacy of Vyzulta were demonstrated prior to this retrospective chart review in 2 Phase 3 randomized multi-center double-mask non-inferiority studies in patients with open-angle glaucoma or ocular hypertension. As we touched on earlier, a mean diurnal IOP reduction of 32% was observed at month 3 in these studies. Vyzulta delivered up to a 9.1 millimeters of mercury mean IOP reduction from baseline, with a mean baseline IOP of 26.7 millimeters of mercury, versus up to an 8 millimeters of mercury mean reduction with timolol 0.5%, with a mean baseline IOP of 26.5 millimeters of mercury. Reflecting on the catalyst Vyzulta SLT patient. So, the 44-year-old male patient I spoke of earlier was the catalyst for our study. As we move forward with further studies, we wanted to know why we might have seen results like these, which included a 44% lowering of IOP after 6 days of treatment with Vyzulta, and how to better identify other patients who could respond similarly. It is important to note that Vyzulta features a nitric oxide releasing moiety, which may be advantageous for several reasons, including nitric oxide facilitates greater aqueous outflow through the trabecular pathway and does not inhibit aqueous humor production. Use of Vyzulta as an initial IOP-lowering agent may be beneficial in appropriate patients whose trabecular meshwork pathology is still in its early stages. To learn more about the mechanism of action for Vyzulta, you can visit vyzultahcp.com/MOA. Vyzulta in your practice. Based on the results of our study, Vyzulta provided IOP-lowering efficacy in newly diagnosed treatment-naive patients with open-angle glaucoma or ocular hypertension, patients with high or normal IOP at diagnosis. We encourage you to think about how Vyzulta can fit into your practice under these and other circumstances. Vyzulta lantanoprostene bunad ophthalmic solution 0.024% is indicated for the reduction of intraocular pressure in patients with open-angle glaucoma or ocular hypertension. Increased pigmentation of the iris and periorbital tissue, eyelid, can occur. Iris pigmentation is likely to be permanent. Gradual changes to eyelashes, including increased length, increased thickness, and number of eyelashes, may occur. These changes are usually reversible upon treatment discontinuation. Use with caution in patients with a history of intraocular inflammation, iritis, or uveitis. Vyzulta should generally not be used in patients with active intraocular inflammation. Macular edema, including cystoid macular edema, has been reported during treatment with prostaglandin analogs. Use with caution in aphakic patients, in pseudophakic patients with a torn posterior lens capsule, or in patients with known risk factors for macular edema. There have been reports of bacterial keratitis associated with the use of multiple dose containers of topical ophthalmic products that were inadvertently contaminated by patients. Contact lenses should be removed prior to the administration of Vyzulta and may be reinserted 15 minutes after administration. Most common ocular adverse reactions with incidence of greater than or equal to 2% are conjunctival hyperemia 6%, eye irritation 4%, eye pain 3%, and installation site pain 2%. Please see full prescribing information for Vyzulta at vyzultahcp.com.